In this video, we will discuss about how to formulate a sensible differential in the MRCP PACES examination. So let's begin. The differential diagnosis is the second most commonly affected skill in the exam for most of the international candidates, the first one being picking up physical science. So for physical science, there is no shortcut and there is no better way than to go to the bedside for clinical practice, and when you're unable to do so, you can look up images online. When you're going through a topic, for example, acromegaly, what you can do is look up images online for the signs that you would be expecting. For example, the coarse facial features, prognathism, etc. The differential diagnosis skill, though, requires practice, and before we practice, we need to know what is actually required and how to structure our thinking according to that. The exam requires us to formulate a sensible differential and mention the correct diagnosis as well. We will discuss with specific examples as to how we can improve and structure our thinking according to what is required in the exam. Let's start with the first case. So usually, the simpler the case, the more difficult it is to formulate a differential. For example, a case of hypothyroidism. So you can pick up some typical symptoms and signs like fatigue, puffiness of face, weight gain, constipation, and in the examination you would find a goiter, maybe delayed reflexes. So it's easier to say hypothyroidism than to come up with a wide list of differentials. What we have to take into consideration is the underlying etiology, any complications or potential associations with it. For example, instead of just saying hypothyroidism, which is the functional status of the patient, we can think about what's actually causing it. So is it autoimmune? Is it Hashimoto's? Is there any relation to the postpartum period, so postpartum thyroiditis? Are there any other hormones that are affected that could result in panhypopituitarism and not just hypothyroidism? Or it could be a part of a syndrome, so autoimmune polyglandular syndrome. We'll take another example. So a patient presents with shortness of breath. This is a female patient who also has joint pains, and on examination we find evidence of symmetrical polyarthropathy, and we can think of rheumatoid arthritis as a potential cause. So a candidate could easily give the differential of rheumatoid arthritis, osteoarthritis, SLE, psoriatic arthritis. So what do you think is the key here? The key here is the presenting complaint, which is shortness of breath. That essentially rules out or negates the possible differentials of arthropathy. So in this case, the correct differentials would be that of shortness of breath. So it could be interstitial lung disease on the background of rheumatoid arthritis, or it could be methotrexate-induced pneumonitis, as opposed to a differential of polyarthropathy. The thought process should start essentially when we're outside the station preparing, when we read the presenting complaint, and if the time duration is given. The rest would depend upon the detailed history, what we pick up in the examination. The vitals play a really important role in establishing whether this is an acute medical emergency or not, and then applying our clinical judgment. In the long clinical consultation, there will be one case of an acute medical emergency, and the second will be a cold case or a chronic case. So in the emergency case, our thought process should be catered on how to deal with it as an actual emergency, how we would react in real life or at the bedside. So the investigations and the management plan should be catered according to an emergency situation. We'll take an example. If the case is shortness of breath, the duration is not given, but when we take the history, we find out that it's an acute case, maybe 1 or 2 days of shortness of breath. We need to modify our thought process according to that. So in the background of rheumatoid arthritis, yes, if the case is chronic, you could be thinking along the lines of interstitial lung disease. Or even in the background of interstitial lung disease, if there is acute worsening, we need to think about some acute causes of shortness of breath. So it's important that we think about pulmonary embolism, pneumothorax, maybe exacerbation of asthma, or a pleural effusion. But this does not mean that the pattern of history is to be changed. It will not start with assessing the red flags. The template will be the same, starting with the presenting complaint, exploration of the main symptom, and then moving on to the red flags. Now don't forget that there could be acute medical emergencies on the background of a chronic case. Coming to the correct order of differentials, the first differential should always be based on the presenting complaint and a unifying diagnosis that takes into consideration the presenting complaint, the background comorbidity of the patient, as well as any potential association or complication. The second differential could be another closely related case or cause of the main differential, of the main presenting complaint. Third could be potentially a medical emergency, and the fourth could be something serious that needs to be ruled out, such as a malignancy. Now, this order is not fixed, and the order of differentials would switch upon based on what the patient tells us. Another important point is to rule out your differential with a clinical reasoning and mention the negating points of your third or fourth differential. For example, in a case of productive cough with long duration, you can include malignancy in your set of differentials, but whether it's your top differential or not depends upon your reasoning. If you found red flags such as weight loss, lymphadenopathy, night sweats, or fever, you could mention it as the top differential. And you found out that these are absent in the patient, then you could potentially put an infectious cause as your main differential and tell the examiner that you would like to rule out malignancy, but against that there were no red flags such as weight loss or night sweats or hemoptysis. Let's take another example. A patient presents with shortness of breath and you find out that the patient has ankylosing spondylitis. Now, the severity or the acuteness would depend upon how long the patient has been experiencing that symptom. It could be a longer duration, and the examination finding would support a differential of apical fibrosis. It could be something more acute, more life-threatening, and more urgent, such as severe aortic regurgitation resulting in breathlessness. It could also be potentially musculoskeletal cause of breathlessness, so you need to find out what the main complaint is, what's causing the presenting complaint, and what's the background. A common mistake that a candidate can do in this case is give differentials of the back pain or the underlying case. So instead of ankylosing spondylitis, they could offer a differential of seronegative arthritides, psoriatic arthropathy, reactive arthritis, etc. So take into consideration the presenting complaint. The next thing that matters is how you phrase your differential. It's better to avoid abbreviations such as RA, SLE, AS, MCTD. Use the full form. Also, when you're mentioning or phrasing your differential, it should include the presenting complaint and the background along with the complication or association, like we discussed in the first example of interstitial lung disease on a background of rheumatoid arthritis.